Hi, this is Elliot Fishman, and welcome to our Facebook Live today. And I just came running across the street from the hospital to the lab. I forgot it was 1 o'clock, so I apologize I'm a little bit late. I appreciate everyone's waiting around, so it's great to be here. And we're getting to the end of August. I'm going back to college in 2 weeks, so it's really a lot of fun. I think if you have to pick one news item this week, and I'm not going to go with Trump or Cohen or anything like that, the biggest news item was NYU, right? Free tuition, OMG. So what a great move by Grossman and the team there. So I think next year NYU will have 147,000 applications from around the world for free tuition. I wonder how the other deans and presidents all over the country, what they're doing, because I'm sure everyone's saying, why are we paying tuition if those NYU guys aren't? Also, I heard that the law school is suing the medical school because the law students don't want to pay tuition. But I guess they have to find someone who thinks giving money to a law school is valuable, not just creating more lawyers, which sue more doctors. So we don't need any more lawyers. My son's a lawyer, but he's different. He's not suing anybody. Anyway, let's get started. And I picked a topic this week on CT of the esophagus, kind of the forgotten organ, because I think on CT, we do certain things with the esophagus. We do cancer. So we look for staging cancer, looking for the presence of nodes. We look for the esophagus sometimes as it relates to trauma, just typical MVA, you're worrying about esophageal injury, maybe stab wounds, gunshot wounds. So you might think about the esophagus with trauma. We think about the esophagus a bit with certain conditions, like achalasia. Big dilated esophagus, you see it down to the GE junction, increased incidence of carcinoma, increased incidence of aspiration. Now, we used to do a lot more tagging of the esophagus. Those who have been doing CT for a while, remember that's the paste we would have. We'd have people take paste. It was kind of the consistency maybe of like cream of wheat or some cereal, and it would coat the esophagus. And radiation therapists still use something like that when they're doing radiation therapy to try to minimize injury to the esophagus. But I think I picked this topic because I'm going to give a talk on CTisus on the esophagus in a couple of weeks. I'm just finishing it up. But to think about the esophagus when you're looking at a CT scan, and because there's many things in the esophagus that can either create pseudo lesions or be important lesions that we tend to overlook. So what things do we think about? Well, what about related to vascularity? So in terms of relationships to vascularity, is my phone, always turn the phone off before you lecture. Important rule. What do you do? So I guess when we think about aberrant right subclavian artery, right? The subclavian artery always goes behind the esophagus, compresses the esophagus. Usually patients are asymptomatic, unless the patients have a ductus of Kummerow, which is a large aneurysm of the subclavian, and then it causes mass effect. We do speak about the esophagus in terms of aortic rings or other vascular anomalies, but typically that's more associated in the pediatric patient. So we do look at it in that regard. If you see the esophagus changing in caliber, you need to be careful to think about some of those possibilities or look carefully. We think about the esophagus in terms of inflammatory changes. We used to see a lot more esophagitis in the AIDS era when people had really bad esophagitis. Those AIDS patients had really bad esophagitis. Fortunately, we don't see that very much anymore. You would see a thickened esophagus, irregularity, sometimes air in the wall, would look kind of like a mottled appearance of the esophagus. We do see that at times, though not as frequently again, in patients who are immunosuppressed bone marrow transplant patients. So surely if you're looking at patients who are immunosuppressed, patients who have AIDS, you want to look at the esophagus and make sure the patient's chest pain or difficulty swallowing or just weight loss is not related to very bad esophagitis. So we can see that sometimes. So again, you think about the esophagus in certain disease states, and that can be very important. We also think about the esophagus in those unusual cases of patients who drink caustic material like lye. You get esophageal strictures perhaps. I mentioned conditions that give you a large esophagus. The most classic is achalasia. Now, of course, if you see a big dilated esophagus, you might say, well, there's obstruction distally, and maybe it's a carcinoma. That does occur. With achalasia, the patients are doesn't have the presentation of cancer. The symptoms have been around for a while, and you see a massively dilated esophagus, but what you see equally impressive is a substantial amount of fluid and food in the esophagus. And yes, you can get that with esophageal cancer, but it's so dilated, there's so much material in there, you know it's achalasia. Remember, it's that classic lateral chest x-ray with an air fluid level we think about. Achalasia, increased incidence of cancer, so sometimes you can have a narrowing of the G junction, but it's really a cancer there, so you need to look carefully. Patients with achalasia are closely followed with endoscopy to pick up early cancers. They often have also cancers of the trachea, so you want to be careful that these patients are really well followed, and I think they need to be well followed. We talk about things related to trauma, injury of the esophagus, but also we talk about T fistulas, trachea esophageal fistula. Now you can see that with tumors of the trachea or lung cancer in general growing into the esophagus. It's kind of uncommon. We've seen a few cases of aortic aneurysms compressing and displacing the esophagus. Okay, that makes sense. We've seen a few of them erode in. We talk about erosion in the aorta with aneurysms. We talk about usually aortoenteric fistula, and usually in my mind I'm thinking about the duodenum, which is where it occurs the most. But occasionally in the thoracic aorta, you can see that process. Patients who had syphilitic aortitis can often get fistulae. Fortunately, we don't see syphilitic aortitis anymore. I've also seen it with patients with tuberculosis, where you have a real prominent retraction and involvement. So that is one of the possibilities as well. Then in terms of the esophagus, we occasionally will see tumors, benign tumors, small outpouchings, submucosal lesions. Leiomyomas are classic. Lipomas are pretty rare, hemangiomas, things like that. We sometimes see outpouchings of the esophagus. Remember, up high, we talk about a Zenker's diverticulum. That could fill with food. The patient can be asymptomatic or symptomatic. Patients can aspirate. So Zenker's is something we do see. It often looks like a mediastinal abscess, and you really need the reconstructed views to really make the right diagnosis. When we go from infectious and inflammatory, we talk about things like hiatal hernias. You can have a very large hiatal hernia and it could twist. You can have a gastric volvulus obstructing the esophagus. So with large gastric hiatal hernias, you want to look at where the esophagus is related to the G junction and stomach, and then try to figure out what the risk is of that patient having a rotation and obstruction, which can be obviously a problem. It can be a surgical emergency. We published a little bit about that a couple of years ago, and Pam Johnson is finishing that gastric volvulus paper, a 3-year work in progress. What else? So with esophagus, esophageal cancer. Now, esophageal cancer, when it's very subtle, you're just not going to see it. And the fact is, the distal esophagus often looks thickened. And when I've seen some of the subtle cancers or Barrett's esophagus, it just looks like thickening. But in the absence of really good distension, it's very easy to see thickening in the lower esophagus. So you want to be careful. I'll sometimes mention this thickening in the lower esophagus. And if the patients are having some symptoms, perhaps endoscopy is a good idea. Maybe you're going to pick up a Barrett's. Maybe you're going to pick up esophagitis. So that's really a definite possibility. What else can you think about? So we talked about trauma. We talked about infection. Again, we talked about congenital. We talked about vascular issues. We can talk again about tumors. Most common tumor, adenocarcinoma. We get squamous cell carcinomas. Again, what you're looking for in patients with esophageal cancer, patients are often getting CT and PET CTs. You're looking for the presence of spread, both the primary tumor, but also looking at nodes. Common nodes from the esophageal cancer would be in the celiac nodal chain. And of course, you remember that typically we talk about nodes being 1 or 1.5 centimeters in size as being abnormal. In the celiac chain with the esophagus, we say anything above 6 to 8 millimeters is abnormal. So one of the things we know is that things like esophageal give nodes, but the nodes are relatively small in size. They're not large, bulky nodes. They can be, don't get me wrong, but they're often small nodes. So it's something that you need to be aware of. In terms of protocols, I mentioned what is it that we can do. So if you're going to look at the esophagus, give the patient oral contrast. We used to use that paste. That paste is hard to reach now. You can't get the paste. Just have them drink when they're on the table slowly so they don't aspirate. And if they're laying on their back and they're drinking, they drink slowly, gravity tends to work in your favor. So that works very nicely. I think people have tried using fizzies, like the double contrast upper GI, but again, that sometimes patients are very uncomfortable, and sometimes patients start aspirating or feel like they're aspirating. So that's something you want to be very careful about. We always will use IV contrast. Obviously, IV contrast helps distinguish things and helps emphasize the presence of normal and abnormal. One of the things we can see in the esophagus, and I'm sure when you were a resident, someone showed you a case like this, is esophageal varices simulating adenopathy of the posterior mediastinum. So particularly in patients with cirrhosis, varices are common. Posterior large periesophageal varices are very common, but honestly, in a non-contrast CT or in a late phase image, it looks very, very similar to nodes. So you need to be very careful not to be confused and call something adenopathy when it's varices. You don't want the endoscopist to be biopsying huge esophageal varices, and almost invariably, the patient has other signs of cirrhosis besides the liver, recanalization of the umbilical vein, ascites, wet bowel. All of those things you can easily see. In terms of some of the questions about Wazaz, hope I'm pronouncing your name right, asked about T-scoring. It's kind of challenging because it's difficult to ascertain the spread of tumor beyond the esophagus. When is it going into the periesophageal tissue, particularly if patients have had recent EUS with biopsy. It is somewhat challenging. Same thing is true in the stomach, though. In the stomach, we're much better. So it's a little bit difficult. Mets, obviously, we look for spread, depending where the tumors are, to the mediastinum. We look for spread into the celiac axis. We look for metastasis into the liver, most commonly, then later on probably into lung. So that part's kind of good. And the nodes, as I mentioned, you really tend to be very strict on nodes. Celiac axis, gastrohepatic ligament, 6 millimeters, worst case 8 millimeters or better, you're going to call those nodes positive, and that'll have a big impact on therapy and selection of therapy. Let's see, any other questions? What else can I tell you? Varices, I have showed a few cases on CTisus. It's one of the great mimickers. Remember, I always make the point that arterial phase imaging in a cirrhotic patient or a patient with portal hypertension is a little bit tricky because you don't know what's varices and what's nodes. You can call something nodes and it's really varices. You can overcall, particularly, occasionally. You'll overcall, but most importantly, you'll incorrectly say things, and we don't want to do that. So in patients where you're suspecting varices, that's why arterial phase is not ideal. It's really venous at about 70 seconds, so all of those varices are opacified. If you do arterial phase, which is what happens because you're looking for hepatoma in a cirrhotic liver, well, then the veins aren't filling in, so the veins look like nodes or look like varices. Posterior mediastinum is a tremendous location for that, but it can occur almost anywhere else. What else can I tell you? That I think is about it. I mean, obviously, we look for things like duplication cysts. Occasionally, we'll see. I had a wonderful gastric duplication cyst the other week. We occasionally see esophageal duplication cysts. Sometimes it's hard to tell tracheal duplication from esophageal. Most of the time, they don't communicate. Esophageal cancer is still a bad disease, but there is some new chemotherapy that is getting better results, but it's not absolutely incredible results. So that's really, I think, a good look at the esophagus. So maybe my takeaway message is you got to look at the esophagus. It's there in every chest CT. It's there in great part of abdominal CT. It's tricky. You often don't have proof, and there's a great tendency to maybe to overcall things. So I think you need to be very careful. You need to understand the different pathologies, and sometimes you'll be able to come up with something that wasn't considered, and Don't forget the esophagus. It's in the chest. And there was a very bad joke, which I can't remember exactly, when they would say, what are the 4 birds that are in the chest? And I think was the thoracic duct. Thoracic duct, okay. I forgot it. I just forgot the rest of the joke. The esophagus, okay, that's kind of like in 5th grade you would have said that joke. And there's some other thing. Anyone has the answer, just raise your hand or something. Esophagus, thoracic duct. I heard that joke in 5th grade. Maybe it was med school, one or the other. Anyway, with that, I'll stop there. And just remind everybody, including myself, we are now doing 1 p.m. Eastern Standard Time, Facebook. Also want to tell people, I came to an agreement yesterday with NVIDIA. They will be helping us build out our deep learning on CTisus. It's going to be spectacular, and it's coming very, very soon. So with that, have a great day, and see ya online. Catch you later. Bye.